we are going to make Dr. Robert Megna the next speaker here. We're just handing over the baton here.
Well, let me give my background a little bit to everybody. I've been in practice for 31 years. I've been doing advanced testing for many years, ever since the days of the original Berkeley lab. But I have used Singulex and now Viridia for multiple years in clinical practice. I own a very large primary care practice. I also own and focus primarily on a very large cardiovascular and diabetes risk reduction practice, in which we look very aggressively at lifestyle management. We do stress reduction, we do exercise, we work on sleep, we work on dental hygiene, we work on healthy diet, great nutrition, and very aggressive pharmaceutical and nutraceutical management of patients. So these tests for me are critical to our patient care and to motivating our patients to get them to do what we need them to do to get healthy. So when we look at inflammation, which we look at all the time, especially the components that we can control, we have our modifiable factors, our non-modifiable factors in our chronic conditions. And modifiable factors, obviously for us, we look at this very deeply because this is our lifestyle management. Our diet, our exercise, quality of sleep, smoking, obesity, dental hygiene, particularly periodontal disease, very, very important in causing inflammation. A lot of our integrative dentists that we work with follow these inflammatory markers and know that, as they're being very aggressive in management of periodontal disease, these inflammatory markers reduce and very important part of our cardiovascular risk reduction. We also want to look at our non-modifiable factors, obviously our genetics and our aging. We may not be able to do a whole lot about aging, but we certainly can affect genetics. When we look at genetics, a phenotype of a process is going to account for maybe 20% of the genetics. 80% of that's the environment that you put in. So if you understand where the genetics is, you can put very, very aggressive lifestyle management to help create an excellent environment for those genetics, so maybe the bad manifestations of genetics would not occur. And then when we look at our chronic diseases, things like atherosclerosis, chronic kidney disease, COPD, cancers, autoimmune diseases, Alzheimer's disease, and the like, all these chronic conditions can cause low-grade chronic inflammation. They can also be a result of low-grade chronic inflammation. So we do want to address these disease processes and, again, implement very aggressive management, both medical as well as lifestyle, in trying to reduce inflammation. What it comes down to is inflammation is the basis of most all disease processes, and really in any specialty of medicine, whether you're a cardiologist, a primary care doctor, an OB-GYN, a psychiatrist, a neurologist, a gastroenterologist, endocrinologist, whatever, you need to understand inflammation because it's what's driving most of the disease processes of things that you're treating. So when we're looking at this reduction of inflammation, and in our practice, we target inflammation. We want to reduce it. We're primarily reducing it by lifestyle adjustments. Optimal nutrition, great diet, great nutrients are very important. Sometimes we'll use nutraceuticals as well, things like curcumin and the like to help decrease inflammation. Certainly quit smoking is a huge factor. Smoking causes tremendous amount of vascular inflammation. It's a main source of inflammation in a lot of our patients with cardiovascular events. We want very aggressive management and lifestyle, this including things like sleep, stress reduction, exercise, weight reduction, and the like. Obviously, when we're looking at our disease processes, we want to monitor these existing diseases, and a lot of it is following inflammation and then treating those underlying conditions. Make sure we're aggressively managing their dyslipidemia, managing their hypertension, managing their diabetes. We want to use all these factors to reduce inflammation. And when we can reduce inflammation, this is how we're going to stop these disease processes from occurring or slow them down tremendously. So when we look at these cytokines, we want to remember that these are the mediators of inflammation. The cytokines are cell signaling proteins that regulate inflammation. And these proteins, there are multiple types: interleukins, lymphokines, tumor necrosis factor alpha, chemokines, interferons, multiple different proteins that we're looking at here. All these things respond to stimuli, to infection, to inflammation, to trauma. We need these processes, we need these factors to occur in order to protect ourselves and in order to be beneficial to our body to stay alive. But where we create a problem is when the chronic inflammatory state stays in place, where these cytokines are continuously elevated, this is where the immune response becomes too excessive, and this is how we end up driving disease progression. So I think for me in my practice, and what we utilize in our practice, is we're at the importance of serial testing when we're looking at inflammatory cytokines. A single test to me doesn't mean a whole lot. It's when I can follow these tests over several months to years. That way I can see whether I'm getting rid of the chronic inflammatory state that my patient may have had, and that's how I'm going to improve their disease process. Let's look at these individually. The first is interleukin 6. We know that it stimulates the inflammatory and autoimmune processes. It induces the production of CRP. This is an important point. IL-6 comes from our vasculature, from our adipose tissues, from other things. That then this goes to the liver, and the liver then produces CRP. We know that IL-6 is involved in multiple disease states, cardiovascular disease, diabetes, and things like rheumatoid arthritis. Next one here is tumor necrosis factor alpha, or TNF-alpha. This one is produced by our macrophages in the adipose tissue, and it's associated with endothelial dysfunction, insulin resistance, and heart failure. This is one of my main markers that I'm looking at to try to identify endothelial dysfunction. We can measure that directly in our practice. We do a test called EndoPAT. We look at it in cardiopulmonary exercise stress testing, where we can pick up microvascular ischemia and endothelial dysfunction. But one of my first blood markers that I'm utilizing, I'm looking for to see is there evidence of endothelial dysfunction, is tumor necrosis factor alpha. It's a very important factor. Now, again, this one's typically associated with obesity. So when we're seeing these obese, overweight patients, a lot of these patients have elevated TNF-alpha. This one here, interleukin 17A or IL-17A. This one's produced primarily by the T lymphocytes. It acts as a potential mediator in inflammatory system. It's associated with the autoimmune response and disease processes. It plays a very important role in atherosclerosis and plaque instability. And that's the most important point in this slide, plaque instability. When we see IL-17A elevated, we generally know that patient's plaque is inflamed. A lot of times we'll apply that in addition to LPPLA2 or other markers of plaque inflammation with IL-17A, and it's basically like throwing gas on the fire. When we're seeing IL-17A, we really know we need to step it up in our treatment on these patients, because these are the patients that are at the highest risk of having an event. One of the big studies that was done with IL-17A was looking at the carotid endarterectomies. And when they took this plaque out of these patients, what they broke that down into patients that were symptomatic and asymptomatic. What they found is patients that were symptomatic that either had TIAs or strokes fairly recent to the time that they had their carotid endarterectomies. Those are the patients that actually had the highest IL-17A. And I think that's certainly indicative of plaque instability. This slide here demonstrates the risk of how we can utilize these cytokines in our evaluation of risk for heart failure. Multiple clinical trials, I'm not going to go through all of these here, utilizing our inflammatory cytokines and one of our pro-inflammatory adipokines resistance in assessing the risk for heart failure. And again, that's one of the things that's nice about Viridia, the previously named Singulex, is that all these biomarkers have clinical trials and evidence to back them up. And this is in major medical literature. This isn't in Reader's Digest that we're pulling this information out of. The last biomarker I'm going to talk to you about here is endothelium. And this one, when we see it elevated, there's usually a major problem going on with this patient. So it definitely gets your attention and gets you going. One of the things that's important, obviously, endothelium is the most potent pro-inflammatory vasoconstrictor known in the body. It's responsible for multiple disease states: pulmonary hypertension, arterial hypertension, kidney disease, allograft rejection, diabetes, cancers, heart failures, atherosclerosis. Multiple causes that can elevate endothelium, and this is where the importance of a very thorough history and physical examination and the use of other clinical laboratory and biomarker tests to help us identify where is this endothelium coming from, so we make sure we target it appropriately to reduce endothelium. Because like I say, when it's elevated, this patient's generally in significant trouble. Here's again our clinical studies and correlations for endothelium. If you look at the first one there, all-cause mortality, hazard ratio 1.54-fold higher for all-cause death. This was published in Circulation in 2012. The next one, kidney function and diabetes. The endothelium elevations were associated with urinary albumin excretion. Next one, obstructive sleep apnea, and this is very important, associated with subclinical sleep apnea. A lot of times if we're seeing these elevated endothelians, it's usually a clue this patient may have severe sleep apnea. We definitely want to be screening those patients for that. Next one, for heart failure, mortality, endothelium levels greater than 5 predicted higher mortality. And then the last one, coronary artery disease progression with high endothelium levels showing odds ratios 6.6-fold for rapid coronary artery disease progression. Again, if you look where these journals are coming from, Circulation, European Heart Journal and stuff, this is not coming from Reader's Digest information. These are major medical journals that are publishing articles utilizing these biomarkers. So just to summarize these inflammatory and anti-inflammatory markers, these really help us proactively manage disease. This is how we can get our patients off the couch and we can get them living an aggressive, healthy lifestyle. We can use these inflammation markers to assess and treat cardiovascular disease. These abnormal levels in the markers can be effectively used to target lifestyle modification, and that's what we use it primarily because it helps these patients when they see their numbers going from red to yellow to green. That keeps them going, keeps them on their exercise programs, keeps them eating healthy, keeps them continuously to work on their sleep apnea and the weight reduction of the wife. And certainly, proper detection abnormalities of these biomarkers helps us give better treatment for our patients and better results with that. This one here, we're going to just do one quick case study, and this is one of the most tragic cases in my medical career that spans over 31 years, and I want to tell you about it. This was a 54-year-old Hispanic male that was brought to me by his wife. He didn't come by his own free will. His wife was concerned something was going on with him. She just couldn't pinpoint it, but she wanted him to have a complete physical examination. She's treated by me. A lot of her family members are treated by me. A lot of her relatives on her side come and see me. And she knows how thorough we are in our evaluation. So she brought her husband over for a physical, and not that he was volunteering to come. He really didn't want to. He's a construction worker. He didn't really have any complaints. His physical examination, he looked like a healthy man. He had a normal EKG, a normal physical examination. He denied everything. He didn't deny any evidence of chest pain, shortness of breath, any complaints, any fatigue. He didn't admit to anything. He pretty much denied anything was happening. And if you look at his labs, on his basics labs, his total cholesterol is 201, his LDL 106, HDL 60, glucose 86, hemoglobin A1C 4.9. You think, well, God, this guy's pretty low risk. He's got a good normal physical exam, looks like a healthy man. He's active, he's physically fit as far as the type of work he does. We plug him into the American College of Cardiology risk calculator. He comes in at a low risk of 3.9%. So generally, we probably blow this guy off. But because we did advanced testing on him, we looked at all these other biomarkers. He had an elevated cardiac troponin I, and we know in primary prevention from our Minnesota Heart Survey that this guy's got an 8.5-fold increased risk of dying over the next 10 to 15 years with elevated troponins above 10. We also see his NT-proBNP is elevated. All his inflammatory cytokines, including his other inflammatory markers, hsCRP, LPPLA2, they're all elevated in this patient. And then when we look at his lipid particles, his ApoB, LDL particle counts are elevated as well. So this guy's got discordance between, his LDL-C and what we're seeing in ApoB and LDL particle count. So this guy isn't a low-risk patient. He's actually a pretty high-risk patient. Again, after looking at these labs, going through the patient again, questioning, examining him, he's still denying any complaints, any issues at all. But, I did finally manage to talk this guy into going to see the cardiologist to get a nuclear stress test done, which he didn't want to do at all. But I finally got his wife to pressure him to do it. So he goes to see the cardiologist. They do a nuclear stress test on the guy, and it is terrible. He's got ST depression on his EKGs. The nuclear imaging lights up. The guy's a mess, and the cardiologist is extremely concerned and recommends immediate catheterization for the patient, and the patient flat out refuses. Says, "I feel great. I'm not doing this." Then the cardiologist is so upset he pulls the wife in. They get on the phone with me. I'm trying to talk to the guy. The wife's trying to talk to the guy. The guy totally refuses and says, "I feel great. I'm not doing any of this stuff." Storms out of the cardiologist's office. Unfortunately, the next week, the guy dies of a massive MI. Now, like you say, it's a sad story, but it proves a point. I think here we got a patient who's very, very high risk, that we identify with our advanced testing. We totally would miss this on physical exam, on history, on basic lipid testing, sugar, glucose, these kind of things with that. So the high-risk patient identified by advanced biomarker testing with it. And then I think when we look at that, even though we had a bad result in this patient, I guess you can lead a horse to water, but you can't make him drink, was that, there's a lot of patients that are out there like this, that advanced biomarker testing is the only way we're going to be able to actually identify these patients. I remember when I first started using, the then called Singulex lab, now the Viridia testing, I thought, well, I'll just use this in high-risk patients. And I thought, well, I'll just use this in high and moderate-risk patients. And then I started realizing, heck, I don't know who's a high-risk or a moderate-risk patient until I actually do the testing, so I can see if I can identify a patient that have underlying trouble. Remember, 50% of people, the first time they present to the emergency room with their first heart attack, they never knew they had heart disease. These are very, very valuable tools to help us identify patients that we didn't know had a problem, and then also besides these primary prevention patients, but also in our secondary prevention patients. So I am a huge advocate of these tests. We use them in our practice all the time in both our primary care practice and our advanced cardiovascular and diabetes risk reduction thing. So that's all I have to say.